Laurentine Fromm, visiting the Carter-Jenkins Center in Tampa, Florida, from Philadelphia today, and I'm very grateful to Dr. Nahara for inviting me and for all of you for hosting me this morning at the center. My topic today is diagnosis and psychodynamics in child forensic psychiatry. And my training is in child psychiatry and forensic psychiatry. The training in general of a child forensic psychiatrist is that we complete our medical school and then our psychiatry residency program, then a child psychiatry fellowship program, and then additional training in forensic psychiatry. I'm a little bit hesitant to use the word psychodynamics in this learned company, and I hope you will forgive me for what I consider to be psychodynamic insights into evaluations I have done, because I'm sure they will seem very primitive to you, but nevertheless, they draw on my own training in psychodynamics and psychoanalytic principles that I was fortunate to have, primarily through my child fellowship at Case Western Reserve University in Cleveland, where I had the opportunity to work with Ehud Koch and Bob and Erna Furman and others at the Hannah Perkins Center there. And that exposure to analytic concepts and psychodynamics and the emotional life of children has, I think, informed my child forensic psychiatric practice. And as I hope to show you this afternoon, has really at times provided the key to the child's experience in the various difficult situations or losses or family conflicts which have come to my attention through child forensic psychiatry. And the other aspect of it, which has been very useful to me, is the concept of, I think, what's called the free-floating attention. So that I try to practice this in my forensic evaluations. And the information, as you know from your practices, the kernel of information which provides the insight into the child's experience often comes at unexpected moments in the contact with the child and family, and I hope to give you an example or two of that. I want to emphasize that child forensic consultation is very different from clinical consultation and treatment, and I will explain some of the differences in this setting. When I was doing my child fellowship program and became very interested in the forensic aspects of child treatment, many of my classmates or colleagues will say, well, why are you becoming interested in forensic psychiatry? And it was my experience that one couldn't really practice child psychiatry without encountering child forensic psychiatric issues in any case, so that one might as well go ahead and get the training to know how to handle these situations in terms of family conflicts, child welfare system, juvenile delinquency. These situations, as you know, are coming up all the time in clinical child psychiatric practice. In 2002, 14 years ago, Tom Gutile, an eminent and articulate adult forensic psychiatrist from Harvard, called child forensic psychiatry a shadowed and undiscovered country, which just 14 years ago, I think it was. This was our first edition of child forensic psychiatric textbook. And in the past 14 years, a lot has happened in child forensic psychiatry. And so now that there are still plenty of shadows in practice, it's not really an undiscovered country. Even the judges now are aware of child forensic psychiatric guidelines. For example, about maybe 8 years ago now, and I was consulted in a custody matter, came before the court. And because of the circumstances, I was only able to interview one side of the family, one of the parents and the child, which is not standard practice in child custody. And the judge asked me, as I was on the stand testifying, had I followed the American Psychiatric Association guidelines for child custody consultation? And I said, no, Your Honor, I did not, because I wasn't able to in that case. And she said, all right, you may step down. She wasn't even interested in what I had to say because she knew that American Psychiatric Association had issued guidelines for that type of consultation, among them being that all the parties should be interviewed. So judges are aware now of these standards of practice. Child forensic psychiatric practice is based on ethical principles which have been established for several decades in the practice of adult forensic psychiatry or forensic psychiatry. And they incorporate those ethical principles into child practice, but there are situations which arise in child forensic psychiatric consultation which do not arise in adult consultation. So there are specific corollaries, so to speak, in child forensic consultation that go beyond the principles articulated in adult practice. And a colleague and I have developed to sort of structure the difference between child forensic practice and adult forensic practice, what we call the 4 C's of child psychiatry. And they are custody, consent, confidentiality, and clinical care. These are 4 areas of child practice which distinguish child practice from adult practice. First of all, before we even begin seeing a child, and this is true for clinical care as well as forensic care, but it touches on the legal aspect of child forensic practice. That is, we always try to keep in mind, how does the law apply to this situation? And when we see an adult in consultation or in clinical care, we see the adult and we start talking, and that's fine. When it's a child situation, the first thing, when I get a call from an attorney about seeing a child for a forensic evaluation, or now, even if I get a call from one parent about seeing a child for clinical evaluation, I ask the attorney or the parent, who's the legal custodian of this child? It's the first thing that has to be established, because I have to know that I have a legal consent to see that child. And many people are unaware or unappreciative of what constitutes legal custody or the ability to give legal consent to the child's evaluation. For example, when I was doing school consultations, and the school said, okay, see this child so-and-so. And I said, well, who's bringing the child to be seen? Oh, the stepmother. And I said, oh, well, that's fine, but I need to have consent from the biological parent. She has not adopted the child, is that right? Yes. No, but as they put it, as the school put it, she knows everything about the child. She's the person you have to talk to. And I said, well, I appreciate that, but first we have to get the legal consent for me to see the child. And they were quite offended by that and said to me, do you mean you're refusing to see this child? And I said, well, no, I would be very happy to see this child, but first I need to have legal consent. And then there was a big fuss about contacting the father, faxing the consent form, getting it signed. But so people really don't grasp that concept. It's very widespread. Or an attorney will say, oh, well, this child has been raised by so-and-so relative. The parents have never been in the child's life. And I say, oh, well, do you mean the parental rights have been terminated? Oh, well, I don't know. I said, well, unless the parental rights have been terminated, they still have legal authority to give consent to the evaluation. And that it causes many incidents of consternation among attorneys. So that's consent. It's a big topic for us. Spend a lot of time on custody, because who has the custody determines who's giving the consent to the evaluation. And there are many different types of consent. As you know, it's consent to clinical care, which now in Pennsylvania, age is now 14. And I don't know what it is in Florida, age at which a child can consent to psychiatric care. It used to be 18 in Pennsylvania, but now has been lowered to the age of 14. And it's the way the law is phrased in Pennsylvania is now, it's phrased in a sort of negative, which is that parents cannot deny a child the opportunity to get psychiatric care if the child is requesting it, if the child is 14 or older. And the other aspect is that a child cannot refuse to get psychiatric care at the age of 14 or up if the parents are requesting it. So the goal of that statute is to make psychiatric care as available as possible to children. But that was very helpful to us because it clarified. If the child says, I want to see a psychiatrist, the parents say no, or vice versa, it puts one in a quandary about what to do. So custody, consent, confidentiality. It's very different, as you know, from in the case of children in care as opposed to adults in care. Because both officially and legally and unofficially, parents or relatives typically have access one way or another to what's going on in the evaluation or treatment. I mean, I always say to children that whatever you tell, this is in clinical situation, treatment, I say to children, whatever you tell me is private, stays here, except if you tell me something that's going to affect your health or your safety, then I would need to talk about that with your parent. I use the term parent to mean legal custodian, just to make it simple. But I will always talk to you first about it. I will say, this is something we need to talk to your parents about, and you and I will figure out a way to do that. So that's the confidentiality. Confidentiality in the forensic consultation is entirely different, because in the forensic situation, I'm going to be talking with at least one attorney about what the child tells me and what the parent tells me about the child. That's my job. Mm-hmm. That's one of the distinctions between forensic consultation and clinical care. That's what I'm there for, to get this information, which is going to be passed along to the attorneys and probably the judge, to be taken into consideration in some legal issue. So I tell the children, and children, as you know, there's a wide difference developmentally and temperamentally how much they understand about this. But I always try to explain to the children what the limits of confidentiality are, and the parents as well. And I say, what you're telling me, it's not going to be private in the sense that I'm going to be talking with whatever they call their attorney or whatever they know the other attorney is. And he's going to ask me to write it up in a report, and the judge will be reading it. So and I say to them, as I say to the parents, if there's anything that you don't want to tell me because it's going to be in that report, don't tell me. And so, but I'll ask you the questions, and I'm going to be writing the answers down. And if you don't want to talk about something, that's fine, but I'm going to write it down just to remind myself that we touched on that area. And it's perfectly fine if you don't want to talk about it. And I explain that I will not be becoming their doctor in the sense of treating them. Which gets on, so the confidentiality is very different in clinical situations, treatment situations, and forensic consultation. Forensic consultation, the confidentiality is reduced dramatically. I mean, theoretically, there is confidentiality within the circle of the legal system, but it's not always the case. Opinions are published online. Things happen. So the family has to know that the confidentiality parameters are very different. And for example, a dilemma which arose in my practice related to this was that some parents brought me their children for evaluation. They had been referred to me by their attorney, and it was a personal injury type of situation. The children had been injured. And the parents said, well, and I told them how I would proceed with the children, and the parents said, I always ask the parents, what have you told the children about this appointment? What do they think it's for? And as I'm sure perhaps has happened to you in treatment situations, the parents or the child will say something. The child arrives in your office and you say, well, what did you think you were going to do today? And the children will, it's a good possibility the child will say, oh, I thought we were going to McDonald's. Or my mother told me I was having an appointment. But that's it. Well, in this forensic situation, the parents said to me, well, we're having this case, we haven't spoken with the children about it, and we don't want you to say anything to the children about what this evaluation is for. And I said, well, I can't really do that. And to me, that gets to really the constitutional concept of fundamental fairness to the child. That's just not fair. It's unethical, in my view, to interview a child under sort of false pretenses. So I said to the parents, well, I understand, your concerns, but I don't think I can really do that, and let me talk to your attorney about it. And I spoke with the attorney, and I said, this is what the parents are saying, and I don't think they appreciate the nature of the evaluation, and maybe you could work with them a little bit more to see if this is something they really want to undertake. Because a forensic psychiatric consultation is by definition not therapeutic in its intent. And it can be very difficult for children and families to dredge up all of these things. For what is defined as a non-therapeutic or an extra-therapeutic intervention. And the other aspect of confidentiality is that, for example, in a custody situation, contemporary guidelines now recommend that the court appoint one evaluator to get away from the adversarial system of one evaluator hired by the mother's attorney, one evaluator hired by the father's attorney, and of course they come to different recommendations. So guidelines now are that there should be one court-appointed evaluator to see all parties and make recommendations to the court. Well, in all probability, the parents will either drag out of the child, or because of the nature of the recommendations or the decision that the court ultimately makes, the parents will know one way or another what the child has said or what the evaluator thinks the child has said. So that's another situation in which we can say, we'll try to have as much confidentiality as possible, even if I'm not saying to the parent, well, look, your child said you did this, this, and this, and that's bad. The parent gets the idea of what has gone on. So what I say to children in that situation is, look, you can tell me everything you want to tell me about your parents, and I don't have to put word for word what you told me in the report. It doesn't have to be a quotation from you, but I'll put down some sort of general statement that tries to capture what you have told me. So there's a cloak of confidentiality, but there really is not confidentiality in that situation. The third thing is, the fourth thing of the 4 C's is clinical care, which is our responsibility to children, the care of children, is a higher level of responsibility than that which is required in the care of adults, because children are, by definition, dependent. And this is, as you know, this is enshrined in mandatory reporting statutes. that if an adult comes to you and says, well, so-and-so did a bad thing to me, we say, okay, well, what are you going to do about it? That's on you. Are you going to call the police or whatever? If a child says to us, so-and-so, this adult did this bad thing to me, we can't say that. Society tells us we have to step in and take responsibility to protect that child. And this idea, as well as the statutory responsibility obligation itself, applies equally in forensic situations, that is, non-treatment situations, as it does in treatment situations. And this can also get very complicated. One forensic evaluation I did of a young child, preschooler, and the child was showing some developmentally inappropriate sexual knowledge or play. And I didn't get the sense that the child had actually been abused, but that maybe it was just a situation in which in the home there were inappropriate things being shown on the television or videos or inappropriate language, which I told the attorney. I said, it was also a personal injury case, but just by the by, this inappropriate sexual material turned up. And I said to the attorney, there are these issues also complicating child's adjustment. And then, so the case is unfolding, the attorneys are talking to each other and talking to the court, and I come to find out that the attorney who has retained me has testified in court without consulting me on this point, has testified in court before the judge that Dr. Fromm will say that this child has been abused, and that's why there are such and such problems. And I almost flew out of my chair because that was not what I had said, not what I thought. And in addition to that, I had not reported this, I'm a mandatory reporter, I had not reported this child welfare because I didn't think the child had been abused. So I took the very unusual step for any of us, and certainly for me, of calling the judge in his chambers and saying, Judge, this is so-and-so. As you know, I have evaluated this child, and I understand that this testimony has been presented to you, and I would appreciate the opportunity to clarify for you what my impression actually is, which I did. And I was very lucky because the judge was open to talking with me, and he listened. He understood what I was saying. So thank you very much. Thank you for calling. So custody, consent, confidentiality, clinical care are all different in forensic evaluation of children as opposed to adults. There's a very nice article it's on the number 1 on the references list, 1997 article, which summarizes the distinction between forensic consultation and clinical treatment called "I'm Wearing Two Hats: Role Conflict in Serving as Both Psychotherapist and Expert Witness." And this article was awarded the prize by our American Academy of Psychiatry and Law because it articulates very succinctly, it's a short article, but very clearly spells out the reasons that, for example, a person who is a treating therapist should not serve as an expert evaluator, and a person who is an expert forensic evaluator should not become that child's therapist. And the reasons for that are based in, number 1, the differences in role. Your role as a treating clinician is to be helpful to the child, help the child get better or the family get better. Your role as a forensic evaluator is to understand the question before the court, make recommendations to the court. The confidentiality parameters are entirely different. And also the stance of the forensic evaluator toward what the child is telling you is entirely different. So that in clinical treatment, we accept what the patient is telling us as true, at least at some level. whether it's emotionally true or historically true. It's true for that patient. In forensic evaluation, we maintain, as is recommended by American Academy of Psychiatry and Law Ethics, a stance which is defined as striving for objectivity. That is, we want to know much more about the historical truth than the emotional truth. Not that we're detectives, but we're sort of emotional detectives, that we look for collateral information in situations of family or the child says, well, this happened to me. It's like, okay, well, that's fine. I'm also going to read the police report. I'm going to ask other people whether they saw this. And we take that into the mix in determining the narrative that goes into the forensic evaluation. So our whole stance towards the patient's relation, or the evaluee's relation of her or his experience, is very different. In forensics, we always have a little bit of skepticism. And I'll tell you an example in which that was brought home to me in a very important way. I'm sort of jumping around in my outline, but in this example is in Roman numeral 6, but the example I'm calling Tom and the Horrible Camp. And I was asked to forensically evaluate a youngster who was then an early teenager. And this child had an early history of intense anxiety and a variety of sort of phobic behaviors, extremely picky eater, couldn't tolerate separation from the family at all. And for some reason, which I'm sure you would understand better than I do, but the family decided when the child was about 9 years old or something like that, to allow him to pick his own summer program. I guess because they threw up their hands, because anything they had ever picked for him he wouldn't do, he didn't like it, it was too scary, he wanted to stay home. So this child, inadvisedly, but employing his fantasy, I guess, he picked a kind of one of these boot camp programs where you go off into the woods and they're very tough, and he was going to, I guess, he was going to beat his fears in this setting. So then going to the end of the line, and I'll fill in the middle, the end of the line was that by the time the personal injury suit was filed about a year later, his attorney was alleging that this child had been made to clean latrines with his bare hands. He had witnessed another child almost drown in the swimming pool at the camp. He had been forced to eat until he vomited, and then forced to eat his vomit, and this absolutely horrifying story. And the attorneys who retained me, in non-custody situations, the adversarial system lives on child forensic psychiatry. So in personal injury situations, that's what we have, the adversarial system, which means there's one forensic evaluator hired by the plaintiff, that is the person who's saying there's some injury, and one forensic evaluator hired by the defense to say, striving for objectivity, not saying, no, this isn't true, but let me look into it and try to figure out what actually happened. And as the benefit that we have in forensic psychiatric evaluations is the benefit of time, which, as you know, in ordinary child psychiatric practice today is a very scarce commodity. When we're expected to do a so-called child psychiatric evaluation in an hour, and the so-called med check, which to me is, I won't do it, I think it's unethical, but that's a sidebar. But we may only be given 15 minutes to see how a child is doing, and to me that's not acceptable practice. But that's not true in forensic evaluations. We can say to the attorney, well, this is going to take 20 hours. I mean, they may not always say, well, I don't want to, they may not say, I'll pay you for 20 hours, but we can say that's how long this is going to take if you want the job done right. So in this particular case, Tom in the horrible camp, as is my customary practice, I read all the depositions from all the staff people at the camp, from other campers at the camp, which my attorney got, read newspaper reports, police reports, read hospital records of when the child I was evaluating was hospitalized shortly after these incidents had happened, treatment records from before and after the situation. And taking all of that into consideration, including the non-corroboration of these events by contemporaneous accounts of other campers and staff who had been there, I came to the conclusion that in each of these instances, there was a kernel of truth to what this patient was alleging, in the sense that, for example, the eating, which he had had eating problems for years, but at the camp, they would say to him, well, you're not leaving the table until you clear your plate. Tough love. And he didn't like that and found that very, it made him feel sick to his stomach. But in his mind, later on, this was elaborated to the extreme that I would throw up and they would make me eat the vomit, which there was absolutely no corroboration of that. So that, interestingly, from the psychodynamic point of view, when this child first returned from the horrible camp, he was very upbeat, he was very confident, he gave glowing reports of camp. It was great. It did just what he wanted, he loved it. And then he started bullying all the kids in the neighborhood. And he found out that the things he had learned, coping skills he had learned at camp, were not going down so well in the civilian situation, so to speak. And then he completely decompensated. Because his new style was not going to cut it, was not going to solve his problems. And that's when he then related about all these traumatic events as he related them. So this is an example of how the collateral information, the corroboration, and the diagnosis, so to speak, I could say to the attorney who retained me, I think this child's problems are really in his personality or his temperament, that he's kind of a fragile child, and at one point he really lost reality testing. This is the way it felt to him. This was emotionally true, but not historically true. And that this was a very unwise choice for him to go to this kind of setting. And the attorney said, thank you very much. That puts us in a much better position. Because they said, well, that was a bad thing, but it wasn't what was alleged, literally. So they were very interested in that. So that gets into the topic of the diagnosis and psychodynamics, and what do they have to do in the forensic consultation. To me, as you also know, today diagnosis is frequently characterized as the checklist, a la DSM, whatever edition. The child has this diagnostic label because of numbers 1 through 10, these symptoms, and that's it. That's the end, the beginning and the end of the formulation of that child's situation. Well, I take a more, perhaps not analytically sophisticated, but I hope at least analytically informed view of the diagnosis. and the dynamics, because to me, in many cases, that's the key to understanding why does the child experience this situation in the way he or she does. And sometimes, on a couple of occasions, has actually been, yes, a kind of viewfinder into the situation itself. It gives the clue to what really happened, or at least an informed opinion about what the child's experience really was. When we write a forensic report, that's typically the outcome of a forensic evaluation. We write a lengthy report about everything we've reviewed and what our opinion is, and then how we synthesize all of the information into our opinion. And then we have to include in that report what's called the reasoning section, opinion and reasoning. And one of my colleagues says that the reasoning section is what distinguishes the forensic report from the clinical report. When we write a clinical paper, we say, well, this, and the child has this, and thank you very much. In a forensic report, we have to say, this is what I reviewed, this is how I understand what happened. My opinion is that the child is experiencing this, and this because of these factors. And then we have to go through all of our information, depositions, clinical interviews, police report, newspaper, whatever it is, and say, these are the reasons in this body of material that I form my opinion. We have to support it in a rhetorically rigorous way. And also, in the event that we're called to testify on the stand, that's very helpful, because then when the attorney says, how can you think this? And we can look at the report and say, well, I think this because so-and-so said this, and so-and-so testified that, and the child did this, and put it all together. So it's not only required by practice, but it's very helpful in those situations. An example, one thing I skipped over, which I want to get back to, is types of evaluations that we do. One is custody, which I mentioned to you, and visitation, or recommending, can this child see this parent, or in what circumstances should visits be allowed. Related to that is termination of parental rights. We have to recommend, should this parent's rights be terminated or not. It's one of the most painful kinds of evaluations. Personal injury, which I mentioned to you about Tom and the horrible camp. That was an example of a personal injury case in which the family was alleging Tom went to this camp and it caused Tom all these problems. Malpractice. Child goes to an emergency room, for example, and then in a case that I recently evaluated, the child was seen in an emergency room and was asked, given the once over, well, you feel like killing yourself? No, this was an adolescent girl. And meaning, no, go away, I don't want to talk to you. Don't bother me. And she went home. Walked into the door of the family home, and went into the bathroom and jumped out the second-story window. Immediately coming home. She was not killed, fortunately, but she was injured. And I was asked, does this, had her treatment met the standard of care or not? It's personal injury. Juvenile delinquency, which is getting into more, all of these previous cases are what we would call civil cases. They're civil realm, that there's going to be some compensation. Juvenile delinquency is more on the criminal side. I'm sure you're familiar with, in adult cases, we have competency evaluations, insanity evaluations, pre-sentence evaluations. Well, in the case of children, they're called not criminal, but delinquency evaluations. The language is different. And the question is, should the child be adjudicated, not judged, or not found guilty or not guilty, but the language for juveniles is adjudicated delinquent or not. And then there's a question of what should be done if the child is going to be adjudicated delinquent, what kind of interventions would be helpful, which, as you can imagine, often encompasses the family situation as well as the child's individual situation. And in our society, there's been an interesting series of Supreme Court decisions in the last 5 to 7 years, which you may be aware of, in terms of sentencing of juveniles and what is constitutionally permissible in sentencing of juveniles, having to do with it's unconstitutional to give young people who committed a crime as a juvenile, they cannot be given the death sentence. That's cruel and unusual punishment. It's not constitutionally permissible. Then, as another case was that juveniles cannot be mandatorily receive life sentences for crimes committed as juveniles. That's unconstitutional. And a lot of the thinking in that regard as related to current knowledge about brain development and how adolescent brains are still developing into early adulthood, so that it's just not fair to make a lifetime decision about an adolescent before the brain has had an opportunity to mature completely. So this is on the criminal side. And also the other point about delinquency adjudications is a lot of these young people ended up when they were tried as adults, they end up in the adult correctional system where, even in the juvenile system, the treatment resources are not always that available or that well done, but certainly in the adult system, juveniles who were funneled into the adult correctional system are very unlikely to get treatment in that situation, and more frequently they're victimized and come out doing much worse than when they went in. This is one thing I had wanted to mention to you was something that Freud tells us about, one of the few areas in which he touches on forensics directly. One of the areas which we're sometimes asked to consult is the credibility of child witnesses. Can this child, if the child has seen something or experienced something, can this child testify? Or under what circumstances can the child testify? And this, for example, if a child is victimized by an alleged perpetrator who's going to be in the courtroom, because the Constitution says that the defendant has the opportunity to confront the accuser face to face. And, common kindness suggests to put a 3 or 4 or 5-year-old child on the stand having to look at this alleged perpetrator in the face can be very traumatic for children. And not only emotionally traumatic, but they may not be able to give genuine testimony because they're intimidated or anxious. So sometimes we're asked to say, well, in what circumstances can this child testify? Should it be by a videotape deposition when the perpetrator's not in the room, or behind a screen, or what? But in one of the few instances that I'm aware of, you may know others, in which Freud comments on a forensic issue, and the issue of credibility. Will a child witness be able to tell the truth? And Freud tells us, which I believe, that adults and children both lie, but they have different motivations for lying. Adults will lie more to be self-seeking or to deny they've done something wrong, whereas children, this is going beyond Freud now, but we know that children will lie to preserve their families because they're ashamed of what happened, they're afraid, and they're anxious about what may happen. So that this, to me, points up the silliness of how children's so-called credibility is frequently tested in the courtroom in the following way. A child will come up or be in the judge's chambers, and the judge will say, "Is my robe red?" And the child will say, "No." And the judge will say, "So that would be a lie, right? If I said my robe is red," the child would say, "Yes." I said, "Okay, fine. So you can testify. You know the difference between a truth and a lie, right? And that's the extent of the test, of whether the child's going to be telling the truth or not. And Freud tells us, and we know, that there are many other potent motivations for a child to lie. Because the child says, I'm not going to say, Mommy did this or Daddy did that. I don't want to be sent into foster care again. I don't want Mommy or Daddy to go to jail. I don't want my parents to split up. I mean, those are the real issues which will drive a child to lie, not whether the judge's road is red or black. But nevertheless, judges go through this exercise because then they can say, okay, well, this child knows the difference between the truth and the lie. Whereas knowing the difference is typically not the issue. Another Freud pearl, which stood me well, I think this is the only time I actually alluded to Freud in the courtroom. There was a young person, a personal injury case, who had, Tom Sawyer out in the woods, these guys are clowning around, and one of the things they did in their explorations was climb one of these power line towers. They have rungs, sort of like steps on them. Not intended to be steps, but that's the way they're constructed. And this was on the railroad line. A lot of juice in there, in the power lines. And this youngster climbed, grabbed the power line, and of course got a big electric shock and was knocked to the ground. And had problems after that, so that this incident happened when he was about 14, and I saw him when he was about, maybe he was 12. I saw him some years later, he was about 19, something like that, say, maybe 20. And most of the time we don't actually testify in court because if our reports are well written, the attorneys say, oh yeah, well, you're right, we'll make a settlement. But this case did go to trial. And this youngster was sitting in the courtroom, and he was then, I guess 20 or 21, in court. And he was there in his t-shirt, like one of these Dennis the Menace t-shirts, and jeans, and which is very much how he looked when I had seen him. And my impression of how this incident had affected him was that he was sort of frozen developmentally from that moment when he had received that electric shock, that he was still acting, talking, acting, behaving like a 12-year-old. He had not advanced at all since that day. And I was trying to explain this to the jury, opposing counsel and the jury, and I said, well, and please forgive me, I'm sure I'm messing up this allusion to Freud, but I said, Freud tells us that we have so many troops in our arsenal of development, and when something very bad happens to us at one stage of development, a lot of the troops are left at that stage. They're still fighting there, so we don't have many troops or resources to bring with us to advance to the next life stage. And I think that the jury appreciated that, although the opposing counsel came up to me and he said, okay, Dr. Fromm, so let's suppose you have 10 troops at your disposal. And I said, well, gosh, I hope I have more than that. But he said, okay, well, whatever the number is. But this idea that I learned from Freud was extremely helpful to me in explaining to the jury what was wrong with this kid, because he was 20 chronologically, but he was nowhere close to 20 developmentally, in psychosocial development. Okay, 2 more examples, and then I'll try to stop. Or 3 more examples. I evaluate, this is an example of how analytic thinking informed my view of a child's experience. I was telling you before about the corroboration and the collateral information, how we try to figure out what actually happened in a situation. Well, in molestation cases, corroboration is usually not forthcoming because most perpetrators have the, wherewithal to make sure nobody else is around when they're going to be perpetrating. And this case was similar to that. This was a youngster who was about 3 or 4, and she was in daycare. And this perpetrator, for reasons that are not relevant, had access to the children there at the daycare. And he built up a sort of, they had these little chairs or pillows or things in the playroom. He sort of built up this barrier and got the child behind this barrier and sexually molested her, which he denied, of course. But the child had later on behavior changed, and she had said to one of the parents, that this so-and-so had bothered her. And one of the things that the child alleged was that this perpetrator had taken pictures of her with a cell phone. This isn't the age of cell phones. And of course he had, the cell phone was lost, and then when they found it, everything was deleted from the cell phone, and you couldn't find anything. And he said, well, no, he didn't take any pictures. Well, when I saw this child, my approach to interviewing children is pretty non-directive. I would have to be a little bit directive in the forensic setting just to get certain through a certain format. But in general, the crux of my interview is non-directive, and I just observe what the child is saying, provide play materials, and say to the child, well, do you want to, in this case, say, here's some Play-Doh. You want to play Play-Doh? Yeah, sure. So she was then about 6 or 7. And she was doing the Play-Doh, and she created something which I had no clue what this was that she was making from the Play-Doh. And she had normal intelligence, she had a good environment, and I thought, what is this child making? I guess most children will make, pancakes or a smoothie or whatever. And I said, what is that you're making? It was about this size. And she said, it's an eyeball. And I thought, oh, that's very strange. And so my hypothesis was that this child had, in fact, been photographed, and that this was looking at her. And so the police actually were able to get a technology person to investigate this cell phone further, take it apart or whatever, and found what this perpetrator thought had been deleted. They actually were still in there, the works of the cell phone, and found the photographs that he had taken of this youngster. And I thought, that play, I can tell you a lot if you pay attention to it. Another example, because the play, to me, in the unstructured interview, gives so much insight into what really bothers the child about this situation. It may not be exactly what we think it is, but this being looked at, that really bothered her. Another example of that was a child who was taken by her family. I forget whether the parents were divorced in that case, but one of the parents or both of the parents took the child to apple picking, that we do in Pennsylvania in the fall. It's a nice sunny day and the apples are ripe and it's a nice family outing. You go to the orchard and pick apples and it's very fun. And these kind parents took the child to go apple picking, and at the farm, the family farm, there was a dog, farm dog had been there. And for reasons no one will ever know, the child asked, could you get her picture taken with the dog? Okay, I'm taking the picture. The dog suddenly, first time ever happened, lunged at the child and bit her here in the throat. And the child was hospitalized for a long time. Surgeries, had to have speech therapy, get her voice back because of the damage to her larynx. And I have a big box of toys in my office, all different kinds of junk in there. Toys and action figures and all that. And as you know, sometimes children, they'll browse over the toys and they'll be indifferent until there's something that they say, that's what they want. And just by chance, I had in that box a kind of an action figure. You're supposed to use it in the bathtub. It was like an action figure of a scuba diver. And he had the tube he put in his mouth, which led to the oxygen tanks. And boy, that's the toy she wanted. That was it. That she just loved that toy. And that's the only one she wanted to play with. And she loved it so much that I said, well, you can take it with you. And she asked me, she said, what is this? And I said, well, this is a scuba diver. And you see that tube that's in his mouth? That means he can breathe even when he's under the water, see? Because this has air in the back. And so he has that tube. It always keeps him safe. He can always breathe. And she loved it so much, I said, well, you can take it with you. Usually I don't do because otherwise I have no choice left. But, and this verges on the clinical care aspect that we always tell children, I'm not going to be your doctor and I'm not here to take care of you. And I was pushing the limits in that case by giving this child a toy that I thought was helpful to her, because we're really not supposed to do that. But she's a little kid. She was so hurt. She loved this toy. And what this suggested to me was that the most traumatic part of this episode for the child was when she couldn't breathe. She was completely dependent on the tracheostomy to breathe. The tube going in her throat was making her breathe. And I thought, hey, if I didn't have that toy, I would never have known that. So that's another example. The last example I want to mention to you, because this, to me, was a gift from Anna Freud to my understanding of this case. And I think in this setting it's appropriate that I mention another one of her many legacies to all of us who have read her work. A child who was 8 years old at the time of this incident, but developmentally delayed, so psychosocially 4 or 5 years old, and who was happened to be profoundly deaf also, was at a school, residential school, and was molested there by an older child, considerably older child, another resident. And the parents took her out of the school because they didn't trust the school, of course, to keep her safe there. And we have in Pennsylvania now, and I'd be interested if you have this in Florida now, we have a series of centers called child advocacy centers, which do investigatory interviews of children who report or of whom it's suspected that they were sexually molested. And these interviews are done by trained evaluators who work just at that center, and they're videotaped. The interviews are videotaped. And the purpose of these interviews is to take away the need for the child to be repetitively interviewed by more and more people, by the police, by caseworkers, by lawyers, so that they do one interview and then everybody can watch the videotape. That's the purpose of it. So I viewed the interview of this child at that center very shortly after the incident that she had reported. And the interviewer, they're extremely structured interviews, because one of the goals is that the interviewer should not suggest anything to the child. Like, oh, well, didn't this happen? or that kind of thing, which can contaminate and affect a child's memory of the experience. So the interviewer did her very structured, kind interview in a sort of child-friendly room with beanbag chairs and all that. And I watched this, but then at the very end, and it was done with interpreters, sign language interpreters, because the interviewer was not signing, it was handing the interview. But she went through the whole interview, and then at the very end, I noticed that this child initiated a mind play with the interviewer. She went like this, and she threw a ball, pretend ball, to the interviewer, and the interviewer, to her credit, played with her. She caught it, pretended to catch it, and she threw it back to the child. And then the child take this pretend ball and put it in her, she had a little bag there. And then she would find it again. And then she would throw it back. She would hide it again. And when I saw this vignette, which to me was the most important part of the interview, I said, that's losing and being lost. This child's losing her ball, losing it, finding it. And that this was the most important part psychologically of this interview. And that clue alerted me to a lot of other material in the depositions and other therapists report that the most enduring traumatic part of this experience for this child was losing her friend, the perpetrator, who she had really been her best friend. Losing her friend, losing her school, which was her home, losing her environment, deaf environment, which was a unique sort of setting for her. And really losing that environment caused her gradually to really decline into a real depression after that. And I thought, oh, thank you, Ms. Freud, for open. If I had not read that paper, I would not have seen, like we say, what you don't believe, you can't see. I would never have appreciated the significance of this imaginary play. So on that note, one more, sorry. The observation. Last example. I was referred to a teenager whose house had been destroyed in a house fire. And some of her siblings had died in the fire. And it was a terrible experience. And I interviewed, it reminds me of it because the court ordered that interview be videotaped. I had to interview the child in her mother's presence on videotape with the child's therapist sitting in the other room to make sure I wouldn't say anything upsetting to the child. I can understand that, but it made it kind of difficult, as you can imagine. But, so I got through the whole interview. I thought, these interviews usually last a couple of hours. And this child was not giving me anything. She's an adolescent. She's been through a lot. And everything was, yes, ma'am, no, ma'am, thank you, ma'am. That's it. She was just, and the mother also. And I thought, oh, I'm going to give up. I'm just not I'm not learning anything here. There's no point in prolonging this. And I said, okay, well, thank you very much, And as I typically do is to kind of transition out of the interview, I said to this youngster, and by then the tape was still running, actually, unfortunately. And I said to the youngster, as I was sort of standing up from my chair, I said, thanks a lot, appreciate your talking to me. And I said, what are you doing this weekend? And she said, oh, I'm going to the mall with my friend or whatever. And the mother turned on her like this and said, oh yeah? Is that what you think? You don't even ask me. You are not going to the mall. You've got in her. And she just let loose all barrels on this kid. And this rant continued as they walked downstairs, out on the sidewalk, to the car. The mother is still laying into her like 60. And I thought, wow. this, I didn't put this in the report, but my impression was, because in forensic reports we don't always put in all we know. We just put in what we need to bolster our opinion, but I thought, this mother is so angry. This was the oldest child. She was supposed to have been on the job protecting these little siblings who were killed. And she still blames her. She is not. It was so painful to see. But I did put something in my report about how the family had not recuperated. It was as if the fire had happened the day before this interview, rather than whatever it was, 3 years before. So I did put in my report that the family relationships were so damaged, and the difficulties that they still had. But that was an example of how the most important part of the interview is not the interview itself. It's something else. But thank you very much for the opportunity to talk with you today, and I really appreciate any tips, insights that you may offer to me about using analytic insight to help inform these evaluations. Thank you.
Thank you.